then the other side of my job is I'm over here at the Neuroscience Research Center. So we're trying to understand hearing loss, what causes it, what we might be able to do to help resolve hearing problems. And I do that more at the bench in the Neuroscience Research Center. And what's cool about our program is that we offer this enormous training opportunity for individuals to come in and witness what goes on at the NIH. We are not the only institute that does this, but we're certainly very proud of our institute for all the efforts that we go through. We take on summer interns, people who are in high school, people who are in college and thinking about medical school, thinking about graduate school. We take on individuals who have finally finished their college degree, but want to get a little bit more of experience in the scientific lab before they apply to medical school. So we take graduate students who are working on their PhD, but doing their actual dissertation science in our laboratory. We do medical student rotations as well as postdocs. So it's really kind of a nice place to be if you're even thinking about starting a career in something like this. Okay, so that's my pitch about the training programs at NIDCD. And again, I realize that you all already have your careers, but as you think about kids, about junior scientists who might want to have these kind of opportunities, I hope you can be a voice for us. So the reason I've been asked to come to talk to you today is I am conducting bench to bedside research at the NIDCD. So what I want to do is kind of go over some of what that entails. So I'll start off explaining a little bit about hearing loss and how we have different types. But then specifically go into my specialty, which is looking at the hearing loss that comes from ototoxic medications. And then the idea of the bench to bedside is obviously we started at the bench, we took it to an animal model, and now we're at a point in our science where we can actually start thinking about the clinical application of what we've been doing. And honestly, this is a small enough group that if anybody wants to stop and interrupt for questions or comments, I'm happy to take that. I lost my, there we go. All right, so hearing loss is our most common sensory impairment in humans. It affects billions of people worldwide at some level. Most often, the types of hearing loss that I'm going to be discussing are caused by the death of sensory hair cells that are within the inner ear. So in this schematic over here, we have the outer ear, we have the middle ear, and then we have the inner ear. This is golden part that I'm talking about when I mention the inner ear. The inner ear is lined with all these sensory hair cells, and honestly, when they die, it's what we perceive as hearing loss. And there are a number of different things that can cause death to these sensory hair cells. There are things like genetic mutations that will cause insult even before birth. There are things that we can expose ourselves to that will also inflict damage to these sensory hair cells. We have noise exposure, treatment with ototoxic drugs, which is going to be the bulk of what I'm going to talk about. And then we also just have aging. With time, these sensory hair cells may die. And what's important to realize throughout all of the signs that I'm going to present is hair cell death in humans is completely irreversible at this point in time. We don't have the ability to regenerate these extremely sensitive sensory hair cells. So our inner ear encompasses two quadrants. We have the vestibular system, and then we have our cochlea. So the vestibular system is responsible for our balance. And there are actually 5 end organs that comprise the vestibular system. So we have 3 semicircular canals, the utricle and the saccule. On the flip side, we have our cochlea, and this is our hearing organ. So we only have one hearing organ. But both of these organs are lined with an array of hair cells that are called sensory hair cells because they have these little stereocilia on top of their hair cells. So in this case, this is the vestibular system. And down here, we have the cochlear, where we have rows of outer hair cells and inner hair cells. So while the morphology looks a little different, depending on what organ you're talking about, the common thread here is both have highly sensitive structures that are prone to insult from external factors as well as biological factors. And anything that causes the death of these hair cells is permanent. So when we talk about the class of ototoxic drugs that might be killing these hair cells, ototoxic is anything that's poisonous to the ear. And we tend to divide these into 2 different classes. We have aminoglycoside antibiotics. These are therapeutic medications that are used to treat gram-negative bacterial infections. So this is streptomycin, amikacin, Neomycin isn't really used in the US anymore for that purpose. Now we just use it as Neosporin. But these are therapeutic medicines that do serve a clinical function that are very helpful, but unfortunately can be very toxic to our ear. The second class is a drug. It's not really a class here. It's cisplatin. It's the world's most effective anti-cancer drug. It's platinum-based, and it is not only the most effective anti-cancer drug, but it is the most ototoxic drug clinically used. And that's actually going to be the focus of what I'll be talking with you all today about. And both common to aminoglycoside antibiotics and cisplatin is they are killing the sensory hair cells that line our hearing organ of the cochlea. But what we've also learned in the lab is that it's also causing damage to other cell structures. So it's causing damage to these cell types within the stria vascularis. This is the lateral outer edge of the cochlear wall. And when we damage these cells, we are disrupting the controlled environment that is required for our ear to function. So these cells make sure that the fluid that the sensory hair cells live in is of a certain ionic composition. And when we destroy these cells, this all goes haywire. The other target that these drugs have is on the cochlear nerve fibers called spiral ganglion neurons. And it's the job of the spiral ganglion neurons to transmit any information that has been sensed by the sensory hair cells and convey that information up to the brain. So when we damage these cells, we're kind of cutting off a lot of the information that we're relying on to understand what we're hearing. And again, I can't reiterate this enough, this drug-induced hearing loss is irreversible. So clinically, we can assess the extent of damage from ototoxic drugs or any of the other exposures that I mentioned using a behavioral audiogram. So this is when you come into the clinic and you either put headphones on or you put insert earbuds in, and someone's asking you to raise your hand or hit a button every time you can hear a sound. And what we're trying to do is figure out the softest sound that you can hear at a different frequencies or different pitches. So when we take that test, you get an audiogram and we plot the softest level that you can hear on the audiogram. So in this case, somebody has responded that they could hear a 0 dB sound at all of these frequencies. So on the y-axis, you have very soft level sounds going down to, sorry, I advanced too quickly. And as you go down the y-axis, you have very loud sounds. So somebody who could recognize sounds being played anywhere in this green shaded region is considered to have pretty normal hearing. We don't expect them to have any problems understanding the world around them or being able to participate in a conversation, because typically we see conversation level a little bit lower down at this volume. But when someone's come in exposed to ototoxic medication, what we often find is that they start to develop a high frequency hearing loss, where the softest level they can hear is low. Oh, I'm sorry, I'm getting a thing, my pop-up. Okay, the softest level they can hear is above level of conversation, which means they can't hear this. They're not even aware it's happening. So this is how we can kind of assess the damage that we're seeing microscopically. So I work specifically in the laboratory on hearing biology and therapeutics. And what's kind of neat and interesting about our lab is that we have lab members who specialize in all elements of bench to bedside. So we have biologists, we have biochemists, molecular biologists that can work at the basic science level to help us understand some of the mechanistic questions we have about why these drugs are causing death to sensory hair cells in an attempt for us to try to understand how we can promote survival. We also have individuals who are trained in animal handling. So we can experiment using a mouse model to figure out what's happening in response to a drug and what's happening in response to a potential therapeutic. And then lastly, we have clinical staff that have the ability to then translate this to the human population in our NIH Clinical Center. So we're really trying to straddle these questions from bench to bedside. So as I mentioned, one of the most common ototoxic drugs and arguably the most ototoxic drug is cisplatin. So I mentioned that this is a very effective anti-cancer drug. This is used to treat kids. It's used to treat adults. It's used to treat a wide variety of cancers. The problem is it's causing this sensory neural hearing loss, which means it's causing damage to the sensory hair cells. And typically a person who receives this drug will get a bilateral damage to their inner ears. So both ears are being affected. And it always starts in the high frequency. I showed you in the audiogram that very sloping shape. So it always hits the high frequencies first, but the damage can spread depending on how much you receive. It's permanent, and it can also be progressive, which I can show you data for that too. And according to the World Report on Hearing, we expect that about 50% of individuals that are adults that are treated with cisplatin will develop a significant hearing loss. And that incidence goes up in the pediatric population. The younger kids tend to get a cisplatin-induced hearing loss more often than the adults do. So this is why it's such a focus of our lab. So many people are affected by this. So what we did was we generated an animal model where we could study cisplatin ototoxicity efficiently. So what happens is we take an adult mouse and we treat the mouse with cisplatin. And in this protocol, we deliver 4 days of cisplatin. So 1 injection per day for 4 days. And then we allow the mouse to recover for up to 10 days. And this is really important because not only is cisplatin toxic to the inner ear, it's also very hard on the kidney, so it's nephrotoxic as well. And you really need the animals to rebound and get healthy again before they can undergo subsequent treatments with more cisplatin. So we really need this recovery period to get the mice back on their feet. And we repeat this cycle 3 times. But what was important here is we're doing hearing tests both before and after the 42-day administration of cisplatin, so we can get an understanding of how this drug is impacting the inner ears of these mice. So this is a large, long, arduous protocol, but we're proud of it in the sense that there are many protocols who throw a lot of cisplatin at the mice so aggressively that the mice pass away after a couple of days. And you don't really get a good understanding of what's happening because cisplatin is not delivered that way clinically. It's delivered in a multi-dose, multi-cycle fashion. So we're trying to replicate that here. And we have great survivability. And we feel like we're better able to study long-term effects of cisplatin on these mice. So using this protocol, we are assessing the hearing both before and after, and we're calculating threshold shift. So this is the change in hearing. And what we're going to do is we're going to plot this we're going to plot it on a plot. And we're looking at the frequency range of hearing for a mouse. So this is different than the audiogram that I showed you. Mouse hear much higher in frequency than humans do. And on the y-axis, we're looking at the ABR threshold shift. So as you go higher on this graph, your hearing is worse. So you can see that mice that are tested before and after who only receive cisplatin have a 0 dB change in their hearing. So their hearing is completely stable. But the mice that were exposed to cisplatin developed this high frequency hearing loss. So this is a robust change in hearing for the worse in these mice. If I were to flip this graph, the same exact data, but now I'm displaying it much like an audiogram, where up top on the y-axis is the soft sounds and down below is the loud sounds. And I equate this to an actual audiogram that was collected from a human. You can see that the severity and the type and configuration of what we've created in the mouse is very akin to what we see in the humans. So this is really providing us with a nice mouse model to study what we are worried about clinically. What we've also learned is that in this mouse model, so this might be the hearing at the end of our protocol, but if we hold the mice for an additional 4 months and we come back and test their hearing again, we do in fact confirm that cisplatin ototoxicity is progressive. We see this in kids a lot. Long after cisplatin has stopped, the hearing continues to get worse. So this is our model that I'm going to be working with as I move forward. So what our group is trying to do is figure out how can we reduce cisplatin ototoxicity. We need to find a therapy that is safe for the person to take, that is effective at reducing hearing loss, but most importantly, it's not going to interfere with the cisplatin efficacy. We still have to fight the tumor in these patients. So we can't introduce a therapy that's going to rescue the hearing, but make it so that the cisplatin can't do its job on the tumor. So this is kind of a strict criteria for us to meet. But what we did was we went back to the basic science part of our laboratory to understand what was happening underneath the surface. So what we do routinely is we extract the temporal bones from the mouse and we dissect out one of these end organs into a petri dish. And over here, you're looking at hair cell density. So we can extract the organ, we can stain the tissue to fluoresce the individual sensory hair cells, and then we can quantify them. So this is looking at hair cell density for per image. And this is in response to no cisplatin. So this is our control. We can see that we have about 18 hair cells per 900 microns squared. But as we expose the tissue to increasing levels of cisplatin, you can see that the hair cell density just completely decreases. We are killing these hair cells from the cisplatin. But what's been interesting is we've learned over the years, and this has been done by our lab, but also a number of other labs. We understand that if you were to stress the tissue, in this case, we're administering heat. So we're heat shocking the tissue. We actually see a benefit. We see better hair cell survival. And what's happening when we're applying this heat is we're inducing heat shock protein expression. So heat shock proteins are ubiquitously expressed throughout your whole body. It's kind of a stress response to any kind of insult. It can be from heat. It can be from injury. It can be from mechanical stress. All we're doing is trying to induce that stress response, that heat shock protein response. And the way we do it is we just warm the tissue a little bit. This is very much a Goldilocks and the Three Bears situation where we just want to raise it slightly. Anything too much would kill the hair cells as well. So this is a little bit of a balancing act. But when we do that, we can see that we have this upregulation of critical heat shock proteins. So HSP is heat shock protein, and you see a number of them listed here in this family. And you can see that in the wild type, we get very little expression, but if we heat shock, we get a lot. Same with some of these other ones. And when we do that, we can actually increase cell survival. So the next question we had is, how can we pharmacologically create this in an animal model? Because we can't heat the entire animal. That would be morbid. So we learned through the literature that statins can actually induce heat shock protein expression. So statins are these FDA-approved class of drugs that are primarily used to manage cholesterol in the clinical population. They're helping to reduce the risk of cardiovascular disease. These have been around since the 70s. They are very well tolerated, and they're commonly prescribed. Our lab and others have been studying statins in the context of the inner ear now for a couple of years to decades. And we're seeing some positivity here. So there was a lab that looked at one of the types of statins called simvastatin, and they found that they could actually reduce the amount of hair cell death when they studied in vitro tissue in response to aminoglycosides. That's the other type of ototoxic drugs I mentioned. A different group used a different type of statin and found that they could actually reduce the damage from noise in live mice. There is another group that looked at atorvastatin to see if they could reduce age-related hearing loss in mice, and they were able to actually rescue some. So then our group joined, and we tried to see if lovastatin could reduce cisplatin-induced hearing loss in mice, and this is published. And it turns out lovastatin does reduce the incidence of hearing loss in mice treated with cisplatin. So some of the data here I'm going to show you, this is still in the mouse model, and this is using atorvastatin. So atorvastatin is Lipitor, if you recognize that, that name of the drug. And what we did was we applied that mouse model of cisplatin ototoxicity that I've already reviewed for you. And we're again looking at ABR threshold shift as a function of the frequency of the mouse, where higher on the graph is worse, lower is better. And at this point, the mice have only received atorvastatin at 2 different doses. And you can see that all of the threshold changes are hovering pretty close to the 0 line, which means atorvastatin on its own is not causing any hearing loss to the mice. So that is not toxic. But both the female and the male mice were exposed to cisplatin, and this group obviously developed the robust high-frequency hearing loss that we expected. But then a subset of mice were co-treated with not only cisplatin, but also either atorvastatin at the higher dose or atorvastatin at the lower dose. And you can see there's a significant difference. The mice that had atorvastatin in their system while being exposed to cisplatin had significantly better hearing outcomes than those that did not. So this was kind of an eye-opening experience for us. This is not complete protection, but it's significant, repeatable, and robust enough that it might be worth following up on. So as an audiologist, I decided that these very, very, very commonly prescribed drugs must be out there in the real world in patients who have been treated with cisplatin, and I want to get my hands on the data to see if I can observe this finding in humans as well. So I put together an observational retrospective study where I partnered with physicians and audiologists at the University of Rochester Medical Center, across the street from us at Walter Reed National Military Medical Center, and with Johns Hopkins, where I actually went and conducted data myself, because this data is actually really hard to find. Most adults don't get monitored when they're undergoing cisplatin therapy. Kids do, but the adults don't really get baseline hearing tests, and I really needed that. So I had to help out and do my own study. But what the criteria for the study design was, I had to have adults that were over the age of 18 years old, and I chose to start with head and neck cancer population. So everybody had to have a confirmed diagnosis of head and neck cancer and confirmation that they were treated for that cancer with cisplatin. And my last criteria was that there could be no bilateral deafness at the time of baseline, because I'm looking at a change in hearing, and I can't really look at a change if you've already maxed out on the audiogram. So the data that I collected was hearing test data that was collected within 90 days of starting their cancer therapy, and then within 90 days of finishing their cancer therapy. So just like in the mouse model, I had these anchor hearing tests, and I'm looking at the difference between those two time points. And collectively, I was able to get data from 277 subjects. And this was retrospective, this was observational. I was not able to intervene at all. But because of how popular and common statin use is in the United States, turned out that 40% were already taking a statin, and I didn't even have to do anything. So this gave me a nice sample set to look at some of these effects. And what's important to recognize here is that the average age of my subjects was about 60 years. And they were mostly male, because head and neck cancer is predominantly a disease that afflicts men in their 5th to 6th decade of life. So we're looking at mostly men, and again, adults. On average, they get about 200 mg per meter square of cisplatin, and that was common for both groups. And nearly everybody gets radiation concurrently with the cisplatin administration. So in this data set, we're going to continue to plot threshold shift as a function of the human auditory frequency region. And again, you see that those individuals that are not taking statins develop a high frequency hearing loss, just like I showed you in the mouse. When we looked at those individuals who happened to be taking a statin at the same time of their cisplatin therapy, we see what we saw in the mouse. We see a dramatic, significant benefit of statin use in terms of the changes in their hearing. But because this was observational, I couldn't control what statin was being used. I showed you data from Lipitor. I also played with lovastatin. It turns out lovastatin is the least commonly popular statin being prescribed lately. So I wanted to see if I could look at individual statins within this statin user group. And it turns out more than half were on atorvastatin specifically. So this is Lipitor. And it looks like atorvastatin was even better at protecting against the hearing loss. And when you mixed atorvastatin with all the other statin types, it's actually dulling the effect. But using atorvastatin alone, you can see a dramatic benefit from the cisplatin therapy in terms of protecting against the hearing. So this was pretty important to us. But trying to argue that there's protection here using individual frequencies and individual data plots isn't really a selling point. So what we've done is we have used that hearing test data, the audiogram, and we have applied the National Cancer Institute's common terminology criteria for adverse events. So this is CTCAE. And you all as physicians are probably well more familiar with CTCAE than I am, because it's a common grading scale that's used to classify or quantify pathologies from any range of disease. So you have a CTCAE grade for pain, you have it for cardiovascular disease, you have it for eye disorders, you have it for almost anything, but including hearing. And what it means is when you have a grade 1 event, it tends to be something that somebody would consider as mild, where you don't really have to intervene, but you're aware symptoms have developed. When you hit grade 2, this is moderate, and this is when you have to start thinking as a medical team if there's anything you could do differently with your approach to treating the patient that might mitigate some of the problems that are starting to arise. So grade 2 is kind of a line of demarcation where we think of something's got to change. And grade 3 is severe. You're going to have to intervene. This person, from a hearing standpoint, will likely need a cochlear implant, certainly a hearing aid. Now, the CTCAE does have grades 4 and 5, but they don't apply in the hearing world. And all of this is based on changes in the audiogram. So in this plot, I'm going to show you the incidence of a grade 2 or higher hearing loss that resulted based on that data that I just showed you. And you can see that nearly 40% of individuals that were treated with cisplatin that did not have a statin on board during their therapy developed this very significant grade 2 or higher hearing loss. These are now going to be hearing aid users, possibly cochlear implant users, and these individuals are certainly going to struggle with their communication in their day-to-day life. But if they just happen to be on a statin drug, the incidence of that severe hearing loss drops significantly, and by more than 50% if you just happen to be on atorvastatin specifically. So this is a better way to kind of digest that plot that I just showed you. So that was incidence. We recognize that this is partial protection, it's not complete. So if we can't completely eliminate the onset of hearing loss, maybe the use of a statin drug can reduce the severity. So now you're looking at the same CTCAE criteria, but you're looking at grade 0, 1, 2, and 3, where grade 0 is there's been no change, and you want that gray bar to be as high as you can be, and it seems that it is with atorvastatin. But what you can see is the grades 2 and 3, the most severe types of hearing loss, is reduced in the atorvastatin users. Non-statin users, nearly 40% grade 2 or 3, as I just showed you in the previous plot. But we reduce it down to nearly 10% in the atorvastatin users. So this is kind of indicating to us that statin drugs have partial protection, and yes, it might reduce the incidence of hearing loss, but if nothing else, it will likely also reduce the severity of a hearing loss that you may be getting. So I'm hoping that the audio is going to hold up for me here. What I've done is I have generated an audio clip of what it might sound like to have incurred a cisplatin-induced hearing loss. So this audio clip is a noisy restaurant where somebody is trying to listen to the specials read by the waiter. And the first clip I'm going to show you or play for you is it's going to be muffled. It's going to be a little bit challenging because this person has now just developed that high frequency hearing loss that generally inflicts a problem on understanding the clarity of speech. So I'm going to hit play.
The salad is a big chicken salad. Includes avocados, almonds, beets, blueberries, raisins, and romaine lettuce. It also comes with a champagne vinaigrette.
Okay, so you're at the mercy of your speakers and the volume setting of your computer. But what I hope you appreciated from that was a challenging listening environment. And that person may or may not struggle depending on how close they are to the speaker. I then want to play you the same environment with the same waiter reading the specials, but now this person had a statin on board where we're seeing that partial protection. And I want you to appreciate what extra benefit that person gets. It's still challenging, but I hope you can actually isolate the individual ingredients on the special.
The salad of the day is the picnic chicken salad. It includes avocados, almonds, beets, blueberries, raisins, and romaine lettuce. It also comes with a champagne vinaigrette.
Okay, so at least for me, I could appreciate what just an extra 10 to 15 dB in those high frequencies might get for me in a real world situation. So at this point, I think we can all agree that statins are safe. They're FDA approved, they're well tolerated, they're obviously prescribed widely in the community. What I'm hoping my data is starting to indicate is that they may be effective at preventing or mitigating the risk of hearing loss in cisplatin-treated patients. But I mentioned earlier, there's 3 criteria here. We also have to make sure that they're not going to interfere with the anti-tumor efficacy of cisplatin. So in the data that I collected, I also looked at survivorship data. So we followed these patients out to 3 years. And what we're looking at here is overall survival of the patient on the left, and then also disease-free survival on the right. So this is the likelihood of the cancer reoccurring. And you can see over the duration of 3 years, there's really no difference between the survival statistics for those that are not taking a statin drug versus those that are, or specifically on atorvastatin. So we have no reason to believe at this point that statins should interfere with the efficacy of cisplatin. And what we're learning from other research done at other universities around the country and actually around the world is that statins themselves might actually have some benefit in the cancer therapy at reducing some of the other adverse events that happen, like fibrosis, stroke. So at this point, the patient should not be taken off a statin drug if they're taking one at the time of therapy. So all of this evidence up to this point is observational, retrospective. We can look at connections, but you can't really definitively determine the effect of statin drug until you do a control study. So at this point, our institute has put together our first ever interventional study to determine if atorvastatin reduces the cisplatin-induced hearing loss in patients with head and neck cancer. So what we're going to do is we're going to invite any adult with head and neck cancer who has scheduled to receive cisplatin chemoradiation that is not currently on a statin medication. They cannot be taking a statin med at the time of this trial. We want the ability to randomize them. So we're going to randomize to atorvastatin at 40 milligrams, which is a very common middle dose, versus placebo. So this is over-encapsulated. They're not going to know what they're taking because this is a double-blind randomized study. And we are going to collect very similar data to what I've just showed you. We're going to collect baseline hearing test information as well as blood work. And then the patients are going to go back to their hospital. They're going to go back to their town and they're going to undergo their cisplatin chemotherapy. That is not part of our protocol. But we are going to ask them to come back for a follow-up audiogram so that we can decide definitively what atorvastatin has done to their hearing. The primary outcome of this clinical trial will be a CTCAE grade 2 hearing loss or worse. But we're also going to look for 2 years to look at survival outcome data. We want to make sure that, again, that the administration of the statin drug during cancer therapy will not interfere with the efficacy of the chemotherapy itself. And at that time, we're going to collect a final audiogram because I want to know if the protection that we may find at the time point here is stable. I mentioned earlier that cisplatin ototoxicity can be progressive. So after they get the hearing test, we're going to take them off of the statin drug. We're going to take them off of the placebo. All medications will stop, and then we're going to wait 2 years and bring them back. So if they did have protection at this time point, we want to make sure that it was maintained. And this, I think, is going to be very critical that if we ever want to apply a statin medication into chemotherapy in kids, I want to know that you only have to take the drug during the cancer therapy to get the benefit. And once the cancer therapy is over, you can come off of it because I don't want to ask a kid to take this for the rest of their life if I don't have to. So I think this last data point is going to tell a lot in addition to what we're going to gain from the earlier time points. So at this point, this clinical trial is open. We are enrolling. We had our first patient enroll yesterday. And this is a multi-site study. So this is a partnership with the extramural community that I defined earlier, as well as the intramural community where I am. So we are partnering with the University of Rochester Medical Center, Emory Winship Cancer Institute in Atlanta, and the University of Maryland Medical Center in Baltimore. And I can hold this slide up for a second if anybody wants to take the QR code to find out more information, or you can just contact me. But we will be enrolling across all 4 sites. We expect that this interventional clinical trial will take about 4 years to enroll because we're looking to enroll about 214 subjects to answer all of our questions. And again, it's open. We're on our way. We finally opened up this month, and we enrolled our first patient yesterday. So this is pretty exciting for us. So in summary, I don't want you to forget the beginning of the talk that indicates that we really have wonderful opportunities to conduct research at the NIH, both at the bench, at bedside. And this is an opportunity that we hope will encourage young individuals to entertain the idea of a career in science and medicine. I've indicated to you that cisplatin causes significant hearing loss in individuals that are treated with it, and that we have a reliable mouse model to study cisplatin, specifically the ototoxic effects of the therapeutic medicine. I have indicated that there may be an opportunity to reduce the risk of hearing loss with using atorvastatin. But at this point, we can't say that definitively because we have to study this in a controlled clinical trial, level 1 evidence manner. And this is underway now. So I want to thank everybody who put time and effort into this story. We have individuals again that were at the bench. We have individuals that were down with the animals, and we have individuals in the clinic that were offering us their data and are now partnering with us to do a prospective study. And as you can see, it takes quite a village.